Okay, BIRADS MRI. So I'll start with the same words, that it's a lexicon for the common terminology between all radiologists. And there is a reporting structure recommendations, and data collections for auditing framework also is needed. First, we start when we report it, or we start evaluating an MRI image. We should start with the clinical information and acquisition parameters. The clinical history of the patient is very important, as we have seen yesterday. It's a multimodality imaging. Breast imaging is multimodality, and so you need the history and the other images of the patient or other examinations of the patient, and why the MRI was indicated. So it affects your evaluation and your examination. Particularly before starting the examination, you should know these information. And also the acquisition parameters are important. You should give them in your report, and you should give the information about the contrast injection. We start with the fibroglandular tissue and background parenchymal enhancement. Fibroglandular tissue categorization is almost same with the mammography categorization. It's comparable. So but for the background parenchymal enhancement, it's new for MRI. We don't have it on mammogram, but we will have it on contrast mammogram anyway. It's categorized as minimal, mild, moderate, and marked. And you should also tell about this. Look for also for the symmetricity of the background parenchymal enhancement. So these are the examples of each category: the minimal, mild, and moderate, and marked for the MIP images. And these are some images that show the parenchymal enhancement of axial images on subtracted images. So symmetricity is very important. Here we see in some cases there are some asymmetric contrast enhancements, and there is a mass here, so we can see the mass in the background contrast enhancement as well. This is a symmetrical parenchymal contrast enhancement, and this is asymmetrical parenchymal contrast enhancement. But when we look at the contrast enhancement, we have different time of dynamic contrast enhanced images. So we should always keep an eye on the first pass of contrast. When you look at the first pass, it is still a mild enhancement, background enhancement, but it's asymmetrical. But you see that it has the glandular, fibroglandular shape. Here is another case. It looks like asymmetrical background parenchymal enhancement, but when you look at it, you see the distortions around the parenchymal enhancement. So it's a malignant enhancement. As Dr. Mendelsohn told you before, you should also keep an eye around the structures of the mass or the enhancement you see. This is another asymmetrical parenchymal enhancement. It's global. It's like the global asymmetry in mammogram, and it takes the shape of the fibroglandular tissue. It does not distort anything. So when you look at the first pass, it's almost same. So always look at every dynamic image. Most of the when it is symmetrical, it's benign. And when you have a lot of non-mass enhancement or background enhancement, it means that it may cause by the hormonal cycle. Some patients with hormonal therapy also show these enhancements, but if there is an asymmetry, there should be a suspicion for malignancy. This is an asymmetric parenchymal enhancement. It looks like it is not. This was reported as normal asymmetrical parenchymal enhancement. It looks like the parenchyma enhancement, but when you look at closely, you see that it retracts the glandular tissue around, the fatty tissue around, or the whole breast. You see the shape of the breast is different. And here is the T2 weighted image that you don't see any brightness on T2 images. When you look at the other breast, you see that fibroglandular tissue is bright, but here you see that it is almost hypoechoic in some areas. So it's a lobular cancer which do not form any masses, but it may look like a parenchymal enhancement. So when you have the ultrasound image, it's still the same. You don't have a definite mass. It's only a hypoechoic region with some acoustic shadowing. So background parenchymal enhancement is mostly associated with younger women. It has higher abnormal interpretation rate. False positives, you have a lot of false positives. That causes higher recalls and biopsy rates, but malignancy rate is less than 1%. And risk of breast cancer increases in high background parenchymal enhancement, but there is no overall difference in diagnostic accuracy depending on background parenchymal enhancement. When there is a high background parenchymal enhancement, you can also detect the cancer in this parenchyma. So the limitation of MRI is background parenchymal enhancement, but not as strong as impact. It doesn't have the impact as the density on mammogram. We start with the mass. In all three modalities, the definition of the mass is same. It's oval, round, and irregular, circumscribed or not circumscribed as the margins. So if it's circumscribed and oval, it's mostly benign. But if it has the other features, it is suspicious. It can be malignant. So this is a very small lesion where we see the enhancement in different time frames, and you see on T2 weighted image that it is bright. When it is bright in T2 images, it is mostly benign. So when you look at the enhancement, it is slowly rising, and you see black septa inside the lesion. So these are the findings that you see in benign masses mostly. So T2 bright and black septa inside, and slowly rising, increasing enhancement. And this shape is oval and it's circumscribed. So this one is quite malignant. When you look at it, it's star-shaped. So it doesn't have a shape, and it has specular margins. And this one is like the first one. It has black septa inside. It's oval. It's well circumscribed. The mass has some contrast enhancement. So when you define the contrast enhancement in the mass, you can just define it as heterogeneous, homogeneous, with dark internal septations, or rim enhancement. So with the homogeneous enhancement and dark internal septations, it is mostly benign, but you should be very careful, particularly in some cancers you may see it. But in heterogeneous and rim enhancement, you must have suspicion for malignancy. So this is a case with oval shape and circumscribed margins with dark internal septations, which is benign. But this case, it looks a specular round tumor with ring enhancement. With when you look at the T2 weighted image down, here you see the necrosis inside, in the center of the lesion, which is bright, but when you look at the rim in T2 weighted images, it's hypointense. This is another case with rim enhancement. So rim enhancement is very important in identifying the malignancy of the lesion. Here is the contrast kinetics. As we do a dynamic contrast imaging, then we can look at the kinetics of the contrast enhancement. The initial phase is categorized as slow, medium, and fast. When it is less than 50% of increase, it's slow. If it's between 50 and 100, it's medium. It's more than 100%, then it is fast. And when you look at the delayed phase, you could just categorize it persistent, plateau, washout. So if it is a benign lesion, it's mostly slow and persistent. If it's a malignant lesion, it's mostly a fast and washout or has a plateau. The plateau is the change from the top of the increase of the enhancement is around 10%. But if it's more than 10% increase, then it is persistent. And if it is less than 10%, then it is a washout. So it is, if it's fast with plateau and washout, this lesion should be suspicious for malignancy. So this is a type 1 curve, which is a persistent with a slow rise. And this is fast with plateau, and this is fast with washout. And fast with plateau and fast with washout should raise suspicion for malignancy. We can see fast with plateau in some fibroadenomas as well, but they weren't biopsy in a way. So this is a small lesion here. It is hypo-intense in T1 weighted image. And this is the first pass, second pass, third, fourth, fifth. So I do not draw any lines. You can draw the graphics. Every machine has it, but I just keep an eye on the different phases of the contrast and understand how it takes the contrast medium. So it's fast and plateau. It looks like a fast with plateau. This is the subtraction image. This is another case with malignancy that you see some black holes inside, and which may be the malignant, necrosis, and you see the retraction associating feature. Another case, this is a lesion here, which is iso-intense with the fibroglandular tissue, and this is the contrast enhancement of the lesion, very fast. And this is another lesion here on the left breast. When you look at the dynamic images, it's mostly a slow rising tumor, which is a benign tumor. And this is a malignant tumor with speculations. It's evident, and you see this retraction of the tissue around. And when you draw the graphic, it's washout pattern with initial fast increase. So for the contrast, if it is a rim enhancement, it is with fast increase and washout or plateau, it's mostly malignant. If it has dark internal septations, it may be a fibroadenoma. So these are three different cases with a rim pattern and dark septations that I showed you earlier. Morphology of the mass is very important when you are evaluating, and you should always look for the terminology, the lexicon, and just compare with it. When you write your report, you will see how it looks like. So always keep using the terminology of BIRADS. It will help you a lot. And always look at the contrast enhancement patterns. There are two lesions in the same breast. The first one here looks like an oval lesion, but the margins are not clear. It's not a very high quality MRI image, but it looks like some little speculations. And this has an initial rise and the plateau pattern, which warrants the biopsy. And this other one, it looks like a speculated mass, but we have some dark septations inside, but the contrast enhancement is type 3, which is an initial rise and then a washout. So the second lesion looks more malignant than the first lesion, but you must look that there is something here, a black hole, and it is white on the T1 weighted images, which is the hilum of the lymph node. So lymph nodes show type 3 pattern of contrast enhancement, and they are bright in T2 weighted images. In T2 weighted images, mostly malignant lesions are not bright, and malignant lesions only have a bright T2 signal when there is a necrosis in the center. So they have a bean or kidney-like shape, and they have a fatty hilum, lymph nodes, and they have type 3 contrast enhancement. So be careful in reporting these intramammarian lymph nodes. This is an intramammarian lymph node with a high contrast when compared to the background enhancement. And this is a lesion which shows a slow contrast enhancement. And when you look at the T1 weighted images, you see fat inside. In the middle, you see some fat signal. When you have fat containing lesion, it is categorized by BIRADS as lymph nodes, fat necrosis, hamartomas, or post-op seromas, hematomas with fat. So this is an hamartoma. This is a mass with oval shape, with circumscribed margins and slow contrast enhancement, and it has a fat content. It is high on T1 weighted images. I see that some of my colleagues do not use T1 weighted images. They use the T1 weighted images with fat saturation, but I strongly recommend you to have non-fat saturated T1 weighted images. This case was called malignant because of the rim enhancement. There is irregular rim enhancement, but in the middle it is black. So it was fat tissue actually. It is a fat necrosis. So fat necrosis can show some irregular rim enhancement, but when you look at the T1 weighted images, nobody has looked at this image, and they report it as a malignant lesion. In the tram flap, it's a flap after the mastectomy, and this is the fat necrosis. So rim enhancement shows, if it shows irregularity, it is mostly malignant, but if it's circumscribed, it is looks like an eclipse. It's the abscess. Here is a case. It's a very small one with rim enhancement here. On T2 weighted images, you see a white central intensity, but around there is an irregular contrast enhancement, a very small cancer. But here it's a very large tumor which looks like an irregular rim enhancement, but when you look inside the enhancement, it is very regular. It is the contrast enhancement around the cyst, which is an inflamed or complicated cyst. So it is called the eclipse sign. This is another case when you look at inside that is quite regular. So it's again a complicated cyst. So one of the problems or challenges in MRI reporting is the non-mass enhancement patterns. It's equivalent to the calcifications, somehow equivalent in mammograms. So non-mass enhancement are categorized as homogeneous, heterogeneous, clumped, and clustered ring. And the distribution is almost comparable with mammogram as focal, linear, segmental, regional, multiple regions, or diffuse. So distribution is as important as the calcification, as earlier Dr. Woodsey has told you. It's most of the linear and segmental distribution is suspicious for malignancy. And heterogeneous and clumped contrast enhancement is probably malignant, but homogeneous is not. Clustered ring can be malignant or can be seen in some cases with inflammation. She had a breast cancer surgery 3 years ago or 4 years ago it was, and there are very small calcifications here yeah, you can see it very well here. So we prefer to do MRI before doing the biopsy in calcifications like this. And MRI showed a linear pattern of clumped contrast enhancement, which is highly suspicious. And this one is a non-enhanced mass, which was reported. This is another case that I showed that is different from the one that I showed earlier in my talk. This was also reported as normal background enhancement, but when you look at the shape of this breast, it is a little bit retracted, and you see some edema in the skin, and there is contrast, and this is T1 weighted non-fat set image, sorry. This is the contrast image, and there is the contrast enhancement. It looks like heterogeneous non-mass enhancement, but it was reported as background enhancement. And this is another case. When you look at it, it looks like an asymmetrical contrast enhancement, but when you look at the first pass, there is still this contrast enhancement, which was DCIS. Here is another case that she had some calcifications, and this is a segmental clump enhancement, non-mass enhancement. These segmental non-mass enhancements looks like a triangle, which the top of the triangle shows the nipple always. When you look at these segmental enhancement, the top shows the nipple. Another contrast enhancement, she has multiple small regions or clusters of calcifications. When we had the MRI, she had a lot of clump contrast enhancements, but it looks like a triangle still showing the nipple. And these are two cases on top. It's a non-mass enhancement. It is a regional non-mass enhancement with clustered ring pattern, as I told you earlier. And this is a non-mass enhancement. It looks, some of the parts of it looks like mass. And so there are some maybe cluster rings, or we can call it a heterogeneous regional enhancement. So this, the one on the top was cancer. The one on the below was, what do you think it was? Cancer? Granulomatous mastitis. So sometimes granulomatous mastitis is frequent in my country, but it's very few in Europe. But it may look like malignant, so you have to do the biopsy to prove it's mastitis. So this one looks like a linear pattern with heterogeneous contrast enhancement, and this is the ultrasound image of the lesion with the ductal dilation. This is a DCIS. So distribution, particularly the segmental and the linear distribution, is very important. You should keep it in mind. This is another segmental contrast enhancement, which forms a triangle which shows the nipple, and this is the calcification corresponding in mammogram. Another one that shows the nipple again, clumped segmental contrast enhancement, non-mass. Again, non-mass contrast enhancement, clumped segmental pattern. And this looks like non-mass enhancement, but it's an asymmetrical, it doesn't have any form. You cannot categorize it with any of the non-mass enhancement terminology. So it is benign changes. due to benign changes, it's asymmetrical contrast enhancement of the background. And this one, this is the T1 weighted image with fat saturated image, and this is the contrast subtracted image that you see something here. It's a duct with signal inside, and there, after the contrast enhancement, there is a focus here, which is enhanced, which has a fast increase and plateau. But when you compare it with the mammogram, there is a calcification on the same side, and so we did the biopsy to the calcification, and it was no, it wasn't DCIS. It was an invasive cancer. So focal contrast is a challenge for every radiologist who is evaluating breast MRI. A focus is unique and stands out from the background parenchymal enhancement, but otherwise has no suspicious features. It means that it doesn't form a mass, it doesn't form some speculations or some changes surrounding the focus. It's smaller than 5 millimeters. Benign changes, it can be caused by benign changes or malignant lesions. Contrast kinetics may help, but may not help. T2 weighted images can help. They may show high bright signal intensity, which is a feature for benignity most of the time. And maybe you can have help from the diffusion weighted images, but they are so small that sometimes you may not identify them on diffusion weighted images. So this is a tiny contrast enhancement here. It is a type 1 very slow rising contrast, and it is type 1, yeah. When you look at the mammogram, always have the mammogram of these patients. Even you can do the ultrasound. There is a calcification here, so it corresponds to the calcification that you see on mammogram. And when the biopsy was done, it was an invasive cancer. It was very small, but it's not possible. It's not possible to identify as a mass. So always have a mammogram when you have MRI. Benign focus is not unique. It is like the other foci in the background enhancement. It has high signal on bright fluid imaging, very important. It may have a fatty hilum. They have persistent kinetics. They are stable since prior exams. So prior exams are very important, or you can just follow them. They may be bilateral and similar. But the malignant ones, unique, they are distinct from the BP, not bright on T2 weighted images. They do not have fatty hilum. They may have washout kinetics. They increase in size compared to prior exams. So this is a background enhancement. You see similar dots in both breast tissue. Again, same, very high background enhancement with some dots which are similar. But in this case, do you see any unique contrast enhanced foci? Focus, or foci. There is one actually which we missed. This is our case. We missed, and she came in 2017 with a cancer here at the same place. So I believe that artificial intelligence or CAD will help us a lot in these cases, but we use some CAD and not convinced yet. So what do we do for focal enhancement? Multiple, if there are multiple, stop, but if there is a different focus like the one I showed you, you should do the biopsy or be very careful about it. With high-risk patients, you may do the biopsy. With personal cancer history, you may do the biopsy. And if the woman is without risk, if the mammogram and ultrasound normal, you can stop. So mammogram and ultrasound is important because you may have some findings corresponding to this MR finding, and that will help you in deciding and making a decision. If there are focal enhancement, it may cause by the hormonal cycle. They are not ductal. They are mostly symmetric. If they are mostly regional and diffuse, and they are multiple foci. These are benign findings. So you should always do the MRI in the second cycle of the menstrual cyclus. If she is having hormonal therapy, then you should stop it and wait for 6 weeks. There are some non-enhancing lesions defined in the lexicon. That is the ductal precontrast high signal on T1 weighted images, cysts, preoperative collections, post-therapy skin thickening, trabecular thickening, non-enhancing masses, architectural distortions, and signal void from foreign bodies. These must be also reported. These are the ducts with T1 high signal before contrast enhancement. It looks like contrast enhancement. And this is a cyst, which is after contrast enhancement, you see nothing. And this is a mass, and after contrast enhancement, it does not enhance. And also, you should report the associating features. I will pass these fast because they were very well defined before me. Or they are almost same with the mammography and ultrasound features. And this is a case where the pectoralis muscle is invaded. And this is a case of lobular cancer I showed you yesterday. And the pectoral muscle is invaded here. This should be reported. And this is a case, but the pectoral muscle is not invaded. There is the contrast, and there is a fluid prepectoral edema. When you look at the contrast-enhanced images, you do not see any contrast enhancement in the pectoralis muscle. And this is a nipple invasion. All must be reported. And axillary lymph node. Axillary lymph nodes are very important now because we prefer to do neoadjuvant chemotherapy in those cases, so you should report them. Another case with a large cancer and axillary lymphodenomas. And after chemotherapy, they shrink. Implants, there are a lot of definition for the implants, but it's another lecture, so I will pass this. So take-home messages, the mass morphology is very important. Heterogeneous enhancement is important for malignancy. Signal intensity may be confusing. Rim enhancement should be kept as a malignant feature. Kinetics is not always reliable, but when there is washout and plateau, you should be very cautious. For non-mass enhancement, asymmetry is very important. Ductal, segmental, linear distribution is important for malignancy. Clumped type of enhancement is mostly malignant. And kinetics may not help you, but just look at it. Focal contrast enhancement, if it's solitary, it's a high risk for cancer. If the patient has self-breast cancer, you should be cautious. Compare always with the mammogram and even with the ultrasound. If they are symmetrical and multiple, it's not important, but beware of the different ones that are in between the sheet. MRI should be done by a breast radiologist, and you should always compare your examination with the mammogram and ultrasound and do the biopsy. And you should be able to do them all, to report them all, and to evaluate them all. And preferably, you must have a MRI guided biopsy option. So thank you very much for your attention. This is a ductal contrast enhancement, which looks like this flower when I change it to orange. Thank you very much.